I'm Susan Branscombe, the host of this podcast, Food Addiction, the Problem and the Solution. Today on the podcast, we are honored to welcome Dr. Jen Unwin. Welcome, Jen.
Hello.
Yeah, thank you for being here.
It's a total pleasure.
Good. You invited me to call you Jen, so that's what I'm going to do. I'm going to read your bio, and then we'll talk about your work and get into some questions. Dr. Jen Unwin is a chartered consultant, clinical and health psychologist in the United Kingdom, and is one of the leading voices in the field of food addiction. With over 35 years of clinical experience, primarily within the United Kingdom's National Health Service, NHS, she specializes in the role of hope in chronic health conditions and how cultivating hope can enhance well-being and support lasting behavior change. A fellow of the British Psychological Society and past chair of the UK Association for Solution-Focused Practice and recipient of the British Psychological Society's Karen Ehlert Lifetime Achievement Award in Clinical Health Psychology, Dr. Unwin has devoted her career to improving outcomes in long-term illness. Her focus is food addiction and identifying effective treatments for those struggling with sugar, grains, and ultra-processed foods. Alongside her husband, general practitioner Dr. David Unwin, she has helped pioneer drug-free type 2 diabetes remission through sustainable dietary change, running primary care group programs that have supported well over 150 patients and influenced many more through education initiatives. She co-founded Food Addiction Solutions and co-authored one of the first treatment studies in food addiction and helped coordinate an international expert consensus on the condition. Featured in the BBC documentary The Truth About Carbs, viewed by 3.7 million people, she is also the author of Fork in the Road, a hopeful guide to food freedom and advocating diets free from sugar, grains, and ultra-processed foods to support both mental and physical health. So you have had quite a career. Wow. Welcome again.
We've had some fun. Yeah.
We've had some fun. Yeah. I've had a long career too, so I can relate. You and I met at the London conference in September, the International Food Addiction Consensus Conference, which we'll talk about, and the initiative there between you and Heidi Yaver. I read the book, which is excellent, your book, Fork in the Road. For anyone who thinks he or she might be a food addict, it outlines brain chemistry and the emotional and mental recovery as well. So let's start by talking about your work, National Health Service, Food Addiction Solution. Tell us about your career and what you focus on.
Yeah, so I did a sort of classical career in clinical psychology, but I decided to specialize in physical health settings. So I always worked in big, tertiary hospitals, trying to help people with various physical health problems to live as well as they could. So they might be disabling conditions, disfiguring conditions, life-limiting conditions, things that really challenge people's sense of self and, can really lead to a lot of emotional challenges in terms of coping. So that was kind of my thing. And you heard that I was a solution-focused therapist, and that worked really well in those settings, trying to encourage people to focus on the things that they value and the things that they can do, and just take small steps towards their goals. That's kind of essentially it. And I did my doctorate essentially in that. So the role of hope, I see that as how do you define hope? Hope is somebody who has a sense of a preferred future and has a sense that they can get there through their own actions. To me, that's like hope embodied. So how can we, as therapists, help people to be more in that position? So that was my doctorate, was about that. But in the background, I'm a food addict, it turns out. I have a lifetime history of yo-yo dieting, struggles with overeating, binge eating, under-eating, I was never diagnosed as being anorexic, but there were certainly periods in my life when you would have said I could have been diagnosed as anorexic. And I was getting towards the end of my career when I heard about Bitten Johnson.
Okay.
I saw her on the Diet Doctor website in a video talking about sugar addiction. And I just thought, well, blow me down. That's me. And I'm a psychologist and I never saw it. And I've worked with other people with other addictions. I still never saw it in myself. But there we are. The scales fell from my eyes. So then I decided to devote myself entirely to this field. And I retired from the NHS. So I don't work in the NHS anymore.
What year was that?
I retired at 55 and I'm 62 this year. So it's nearly 7 years ago.
7 years ago.
Focusing on this work with Heidi and all of you lovely people internationally.
Yeah.
And seeing, you know, how far we can get basically, because it's something that's changed my life. And, you know, I know how many people are suffering and are in that same position as me of not understanding what's going on for them, who are still blaming themselves.
Yeah.
Where, you know, really they mustn't. That's never going to help any of us. So so that's how I got to where I am today.
Yeah. So blaming themselves, what we know is that our brains change when we ingest. Often addicts ingest sugar, ultra processed foods, those kind of things that it sets off a dopamine response, right? And so we want more. That's what I blame myself for all those years, and it sounds like you did too, and others do. That's my purpose here is to make sure people understand it's not your fault, right? Say more about that.
Fault. Yeah, not your fault. And there was always this sense of more, wasn't there? Needing more. It was never enough. But that is really the defining thing about addiction, is that it's never enough. But that's because of the substance, not because of any lack of willpower or moral failing. And we often would say, Heidi and I have done together, obviously the intervention study, but also weekends where we take people away and, you know, immerse them in all of this stuff and all the good food. Right. And, you know, literally people in tears when we say it's not your fault, people bursting into tears because nobody's ever said that. It's always been about, why can't you just have a little bit? Why can't you be a normal person?
Right.
Moderate what you eat. And we're not normal in that way. And actually that, what Bitten loves to say, isn't that something to celebrate, that we've got these special brains that, yes, they get us into trouble with food and maybe other substances because they often go together. But also we've got these fantastic lively brains and, you know, we just need to feed them right, nurture them right, look after them right. And then we get to achieve all these, you know, why were we put here on earth with our special brains? And we need to work that out. And,
yeah. So you take the food out of your life as a priority, you know, and then you can go on and do things that you're meant to do and not have to focus on food and weight all the time. But talk about the substance use part, and we'll talk about your work with the WHO and the ICD. But some people don't understand that already in the APA, American Psychiatric Association's DSM, the manual for diseases, anorexia, bulimia, binge eating disorder are in there as behavioral addictions. What the movement is, and talk about food, ultra processed foods specifically, like alcohol and drugs, is another substance. And so that's what the effort is. Talk about food as a substance use disorder.
Yeah, so that's the effort, is to get the condition recognized, because exactly as you say, there is no diagnosis of food addiction, or we can talk about what we should call it, because that's what the consensus was all about. Really, that exercise was, you know, what can clinicians, academics, researchers, people working in this space, you know, maybe even people in the public who are suffering from this condition, what could we all agree about what to call it? Because I think there's the fact that there's a confusion doesn't help our case. So some people say sugar addiction, some people say carb addiction, some people say food addiction, some people say ultra processed food addiction. So there's all of that going on in the space. So when we got our 40 experts together, what they were 38 of the 40 were able, and I know one person has changed their mind since then, so it would have been 39 out of 40. Agreed was that for various reasons it would be good to use the term ultra processed food use disorder. Because that's where the most research is, that's where the most evidence is about the harms of those foods and the effects that those foods, as you've already alluded to, has on the brain and the body. But also it points the finger where the finger needs pointing, which is at the substance which is causing the problem, not the behavior. Not, as you say, food addiction could be seen as a sort of behavioral disorder, couldn't it? And a lot of people believe it to be so. They believe it to be so. And I think, of course, all addictions are, to some extent, both. They're behavioral and substance. So alcohol, nicotine, we all get in habits around those, or we're cued by certain things to do with those, or there's social factors to do with it. So of course all addictions are behavioral to some extent. So you've got sort of gambling on the one end, which is purely behavioral, has these effects in the brain, the same effects that you've already mentioned.
Lights it up.
You've got things like cocaine and heroin at the other end that are very substance related. And then we've got this in the middle where people are sort of, going to argue the toss about whether it actually exists. But I think the evidence is growing. There's this differentiation. The other thing that the consensus focused on was, yes, there are eating disorders. Nobody's going to deny that. Those exist. That doesn't mean the food addiction doesn't exist as a separate but related condition. So I was mentioning right from the start, there are times in my life when my behavior might have been diagnosed as an eating disorder. I think a lot of people in eating disorder services actually have food addiction or have an eating disorder and a food addiction, because you can have both, or you can have one without the other and one without the other. And I think we need to, David Wiss is so brilliant at this, bringing these two spaces together, these two fields, trying to kind of make bridges, because the eating disorders people think that we're talking about a severe form of restriction, which is going to worsen eating disorders.
I'm familiar with that.
We think, of course, that everything in All Foods Fit, which tends to be the eating disorder people, is going to be a disaster for people like me and probably people like you, because All Foods Fit would have left us trapped in that awful dependent place with, just making the addiction worse. So, that's a good explanation. I would like to go a little further in this, in that I did interview Dr. Kim Dennis on, who, as you know, was in London and spoke at the conference. She's really extraordinary. And she talked about something that is an incredible statistic in that, and she's in that eating disorder camp, but she knows food addiction exists, right? She's one of the 40 or so in the consensus. She said something to me which makes me think that there is a food addiction component here that we're not looking at, and that is, of the eating disorders that are treated, 30 to 50% of those treated for food addiction, treated for eating disorders, aren't successful. So she said there's something else going on, and I would like your opinion. They're not good. Agree. When you look at the outcomes, you're thinking, for a psychosocial treatment model, which is usually what you get with eating disorders, you'd expect slightly better out. I mean, no treatment intervention is universally effective, but it's not very effective, their treatment, and there's a lot of relapse as well. So I completely think there's a component missing. And if you look at the prevalence data using the Yale Food Addiction Scale, which is Ashley Gearhart's scale, which everyone uses in research, and thank goodness, because there's thousands of papers now, But there was a really good paper in about 2023. Praxides and colleagues, a big group, looked at all the studies using the YFAS, and they showed this big overlap. And that, I think particularly in binge eating disorder, I think it was maybe, I might be quoting it wrong here, I think it was maybe 50% of patients with binge eating disorder had food addiction. There's even a proportion of patients with anorexia have food addiction. We know it's higher in obesity, type 2 diabetes. I just think it's this condition which people are up to now generally blind to, and the health service is blind to. You can't get treatment over here or over there, I guess, on the
on food addiction. Right.
On food addiction, if you got sent to an eating disorder service, well, we've already identified that might be problematic, but that's probably where you'd get, if you went to your doctor and said, I can't stop eating sugar, they'd probably send you to the eating disorder service, but they wouldn't know how to work with addiction. And if they did send you to addiction service, which they may do, they don't know how to work with food because they work with alcohol and drugs.
Yeah.
So there's a big gap. And that's another, real campaigning point.
Yeah.
Is that people aren't getting the treatment they need.
Right. And that's where I wonder what you would say about this barrier between the eating disorder camp that's saying food addiction, no, all foods fit. If you start talking about food addiction, we can't treat the eating disorder. There's a real, what I would say is a closed-mindedness and a resistance completely to food addiction as a real substance use disorder, and focusing on the eating disorder. And until I think the two come together, we're not going to make the progress we need to. I'd love to hear what you say about that.
I completely agree. I think it's absolutely essential. And I think it goes the other way as well. I think, we mustn't be practicing in food addiction without understanding eating disorders, diagnosis and treatment, because you could equally, if you're treating someone who's got an eating disorder as if they've got food addiction, you could equally be doing some harm. So you can do harm on both sides. So I think the two fields 100% have to come together. And that's a diplomacy issue. It's about the science, it's about education. I think it will come. And there's definitely, there are people like Kim, people like David Wiss, other people, Timothy Brewerton. There's lots of people now who are straddling the two fields in terms of clinics, but also in terms of research. So I think it's going to come. And we've submitted a paper. I've got another colleague in the UK called Ellen Bennett, and she gathered some data on binge eating symptoms as part of her food addiction treatment study. And binge eating symptoms improve. So the big criticism from the eating disorders guys has been, you're going to make eating disorders worse, particularly binge eating symptoms. Well, now we've got a couple of papers, we've got data which show that actually binge eating symptoms improve. So I think what we do is we take every argument that's made against the existence of food addiction, we do some research, and we, you rebut it with data. It's exactly what David and I had to do when we started doing the work with the patients with type 2 diabetes. It's exactly the same. You just need to keep getting the data and keep pushing it out there.
Yeah, the science will speak for itself, I think.
It's not. It's necessary but not sufficient, if you like, the science. So you need the science, but then you also need the campaigning side.
Yes.
And I think the public.
You have to sell.
This is the kind of thing that the public are increasingly getting behind. Certainly in the UK, there's been a real wind change around ultra-processed foods. A couple of campaigners over here. Scott Tulloch's one, who's written a fantastic book called Ultra-Processed People.
Yes.
They're well-known people in the media, and I think the public is really now checking labels, trying to buy real whole foods. And of course in the States, it's really taking off now.
It is, we have a HHS, Bobby Kennedy, Bobby Kennedy Jr. going after this and really focusing on it. So we're changing the food pyramid and all of that. So there is a focus on this in a way that we're seeing a sea change. So it's happening. But I'd love to know more. It seems like the perfect combination for a food addiction recovery program for you as a psychologist and David as a GP. So there you go. You've got the physical, effects
Yes.
of food addiction, and then the psychological. So talk about how you work together. And I know from one of the podcasts I listened to, you really like groups and
Yes.
how good groups are. So talk
Oh,
about your work there and what you've seen.
yeah, I love groups. So this started about 13 years ago. It actually started before I realized that I was a food addict. But what I had found at that time was I read a book and it was called Escape the Diet Trap. And I thought, oh, that's me. I need to read this book. So I read this book. It was by a British GP called Dr. John Briffer. I think it's still in print. And really that was all about reducing refined carbohydrates and sugar in the diet, because that drops insulin. And if you drop insulin, you go into fat burning mode. The brain loves it because you're burning ketones. And you're losing weight because you're not fat burning, and you're less hungry because insulin is the hormone of hunger, you see. So I'm thinking, wow, this is pure genius. And because I'm a bit of a scientist, I was thinking, right, so I jump in both feet. Cold turkey, felt terrible for about 8 days, then felt fantastic. And so David and I were thinking about his patients with type 2 diabetes and obesity, fatty liver. He'd just seen those conditions, grow and grow in people. The numbers of people, younger and younger people coming through with diabetes and obesity that he never saw because he's older than me, so he's an old GP. He'd never seen that when he was the oldest patient with type 2 diabetes would be 65. The youngest would be 65. Yeah. I'm sorry. And now he's got patients in their 20s. I think he had one teenager who had type 2 diabetes diagnosed. So this was really upsetting for him, because he's a very sort of caring doctor. So we decided to do a project where we help people with type 2 diabetes to do exactly that, to reduce the refined carbohydrates and sugars in their diet. So those are the foods that are going to be raising your blood sugar. So that makes perfect sense physiologically. But also, as it turns out, as we know now, those are the foods that drive hunger, that drive overeating, they're lighting up the brain with the dopamine. Yep. So, and we know that there's this overlap, that if you've got food addiction, you're 7 times more likely to be type 2 diabetic. So, there's this big overlap between type 2 diabetes and food addiction. Yeah. So we started, because I've always been a fan of groups. I've always run groups as part of my practice, because I think people with long-term conditions can get isolated. We've already said they feel ashamed. They maybe don't feel supported, not got the right information, and groups are perfect for all of that, because they see other people just like them with exactly the same problem, who are trying to get somewhere better. It's this kind of hopeful, we're trying to improve our health. We're kind of supporting each other, and it's just wonderful what could go on in a group in terms of supporting each other. And you get the ones who, early on we had one guy who's actually been written up in the British Medical Journal, who came off, I think it was 6 medications, reversed his diabetes, drug-free, lost 10 stone. Let me think how much that's a lot of kilos. It's like
a lot of pounds too.
It's a whole person. Yeah.
A whole person.
He lost the whole person in weight. He was depressed, he started going to the gym. Anyway, people like that are so inspiring, because he's just, the guy down the road, and he's done it. So he can
he's done it.
Helps other people. He's a very inspiring guy. So group's brilliant. And we started getting these amazing results, and we were like, wow, there's something, this is really something. And it wasn't something that people were doing at the time. Low carb it was definitely not sanctioned in the health service. I mean, it isn't still really now. And in fact, David would go to conferences and get shouted down, you're going to kill everybody. Yeah. So we gathered all the data. So now we've got 15 years worth of data of what happens to people that adopt this, we'll for shorthand call it a low carbohydrate diet. And
he hands them a food plan, right? He gives them here's what you eat and not eat.
Yeah, there's a food plan. He's got it on one sheet. In fact, I can send you the link. This is all open access to people on the Public Health Collaboration website. It's got lots of little infographics about how much sugar. See, people know about sugar, but they forget that, say, 100 grams of basmati rice is like 10 teaspoons of sugar, or a banana 6 teaspoons of sugar. So if you've got diabetes, you want to be avoiding those foods, because
high glycemic index.
they're going to just be digested quickly down into sugar and bump up your blood sugar, and that's what causes the problems for people. So we do all that education, but they also get the support, and because it's a local practice, it's in the local community, so that guy, for example, is still coming back now. So he still comes to group after 15 years to help people and to keep the motivation up, because as you and I know, he would probably be he definitely would screen positive for food addiction. That it's not about a quick fix for us.
Right.
It's a lifelong struggle, learning habits, trying to look after your well-being. It's just such a complex thing to stay in recovery. You're getting into recovery is that's one thing. It's really staying there is
staying in thing. Yeah. David, so he has someone coming in that, let's say, is 100 pounds overweight and type 2 diabetes, high blood pressure, all the things. And then so he gives them a food plan and says, okay, you need to talk to my wife and
well, no. He would. I've trained him really to be able to do most of it now.
Okay.
So I don't see I just occasionally will see his individual patients if there's a real complex addiction problem.
Yeah.
But I tend not to. He can do it himself. So
yeah.
he'll talk to them about what would be better in your life if you could tackle this problem, and I can start lifelong medication today, he'll say, or do you want to have a go at doing it without medication, and we'll work together. So it's finding that person's real motivation to get well, stay off the medication. And then he explains the physiology, like I just did really quickly about insulin. If you have sugar, insulin goes up, fat storage goes up, hunger goes up. The body doesn't. People are always really surprised when we say, you can actually live without any carbohydrate. There is no essential carbohydrate, because the body can burn fat, and of course that's much better because then you're losing weight. And actually, the brain really loves when it's living on fat. It's kind of, it's more lively. It loves fat as a source of fuel. Mitochondria love fat as a source of fuel.
We need fat.
We've all got fat phobic, because of the guidelines.
Yes, right.
So he explains all that, and they all go, "Wow," and here's what you can eat. Okay, and he says, right, and he weighs them if he can. Some people he's had some people are just even too heavy to weigh, but then he will measure around them. And he says, "Well, I'll see you in 2 weeks, and we'll take it from there.
See how you're doing."
They join the group, hopefully. I mean, not everybody does, but if they're interested, they'll kind of join the group, and then we do recipes, and there's a WhatsApp group, and it gets that way.
Well, we know that. A couple of points to make. We know that obesity can be a symptom of food addiction, but not necessarily. And there are food addicts out there that are not obese, maybe not even overweight. So let's just say that. But
there's a good proportion that are normal or underweight. And Heidi won't mind me saying that she's one who's always been sort of normal underweight.
Okay.
All her life, she was never able to put on weight, and in a way that was a curse, because people would say, "Oh, you can eat anything." So she literally ate anything, and then was malnourished essentially because she wasn't eating. So we've said carbohydrates aren't essential. What is essential is a protein, amino acids. They're essential to life and to your brain and your body repairing itself. And essential fatty acids, which we need again for the brain, for your hormones, all of these things. So what can happen when people are food addicted is they don't eat those things because they'd rather be eating their drug foods. And so you've got a malnourishment problem as well. People's brains are not only addicted, but they're malnourished and are trying to kind of signal by still, pushing you to eat, is that, they're trying to get some vitamins, fatty
Yeah.
acids and amino acids, and that part of the foundation of recovery, as you've already said, is to be eating the right foods that heal
Right.
your body and brain, so that you're not missing those macro and micronutrients in your diet, because we're trying to replace blood cells and bone and brain cells, and all of those things are turning over all the time. You can't build we often joke, well, you can't build a human body out of porridge oats and bananas.
No.
Those aren't essential components of the body.
No,
sadly.
No, it's toxic. And I want to go a couple different places with you here. One is that I know you're a strong believer in the low carb, no carb, keto diet, and we can talk about that. But what I know you know, is that food plan is only one part of recovery. So, we can get real focused on, okay, what do we need to eat to get better, feel better? And that, abstinence from those foods without some support groups, whatever. I'm in a 12-step recovery group. And so every day I'm doing work where I used to use food to handle those things. I have a 12-step recovery program. So I know what you believe about in terms of what people should be eating, and you and David share that. But I'd like to talk about recovery. How do you see recovery necessary for people to be successful, to have the highest success possible?
Yeah, absolutely. Because most of us were using food as an emotional management strategy. So
yes.
So we need to learn some other emotional management strategy, or strategies preferably, because we're just going to be drawn back in otherwise. So yes, the food is the foundation, and we do find that people's mood and in terms of anxiety, depression, other well-being factors, does stabilize to some extent with the right food. That's a big foundation. But life happens to all of us, or maybe there's trauma history, or maybe we've got these super lively brains that we find it hard to tune out, because we maybe there's a big overlap with, say, for example, ADHD, attention deficit disorder. We see a lot of people, maybe on the spectrum, coming through for treatment, because we've got it's these kind of special lively brains. We need other ways to calm down. So in the book I talk about people have to find their own way. I think the 12-step programs are brilliant. They help so many people. They're accessible. You've got that sense of community. You've got the group. I think that's fantastic, and that works for so many people. So I highly commend those approaches. For those that either don't want to do that, or they want a different approach, there are other communities that you can join. There's a few of online communities that you can join. Some you have to pay for, but there's Sugar X Global, isn't there? There's Sweet Sobriety.
Bright Line Eating. These are all ways. Right. Smart Recovery kind of takes the spiritual part of this out, if you have some agnostic beliefs, because 12-step recovery is very spiritually based, higher power and all that. Some people are a little resistant to go there, but there are many ways to recover.
And you may have to try a few. It doesn't mean that, again, it doesn't mean you're a failure if something doesn't work for you. Just keep trying something else, because there'll be something else. In the book, I talk about this idea of getting your daily dose, where D is for dopamine, O is for oxytocin, S is for serotonin, E is for endorphin. So I personally really focus on, what am I doing every day? What habits am I doing to look after myself? Because otherwise, I would always prioritize looking after family and work. I wouldn't have taken time to think about my own well-being, or what I was going to enjoy doing, or what was sort of recharging my own batteries. I was always running on empty, and I think that's sort of the metaphor. I was running on empty, so I was trying to kind of fuel myself with banana sandwiches or whatever it was, that I was trying to kind of fill that gap. So dopamine, obviously, exercise, again, I was a hater of exercise at school, particularly. I abhorred it. I thought it was the worst invention ever. But I now have a form of, find something that you love. Again, it's that same issue. Find something, it doesn't have to be a particular thing, but some form of movement that you love and you're willing to do on more or less a daily basis. And it could literally be walking. I do walk every day, but I also do some other things. So try and walk every day. Human beings were designed to move and walk.
Right.
We get dopamine. If you're outside in the sunshine, you're also going to get serotonin from that.
Yes.
Which
right.
is the feel good, kind of relaxed. Oxytocin is your closeness. So have you got a pet? Have you got a loved one? Can you get yourself a massage? Something that's, very nurturing.
Right.
Is your oxytocin. Endorphins, exercise is also brilliant for that. Or, a lot of people now doing this, like the cold plunge stuff or the sauna stuff. And there's lots of evidence that really does give you that endorphin.
That boost. Yeah.
Kick.
Meditation helps too.
People with meditation. Yoga's fantastic as well, really, for all of it. Yoga can be really, really helpful because the breathing and the movement tends to calm the mind down. So I think it's just paying attention to those daily practices that, maybe left to your own devices, you would not do on a routine basis. I wouldn't. If I could choose not to go to my boot camp every day, I wouldn't go, because it's, these things are a little bit of suffering. But as who wrote the Dopamine Nation, Anna Lemke tells us, dopamine is that thing about the balance between pain and pleasure. And if you're always pushing on the pleasure pedal, you're going to get pain anyway. So you might as well push on the pain pedal some of the time. Right. Go walk in the rain, have a cold plunge, go do your boot camp, and then you just feel so much better.
You just feel better. Yeah. It's not about, I would say it's not about motivation either. You might not be motivated to do it, but as long as you're willing, I might not feel like walking, but as long as I get out and do it. But the point I think you're making is find joy in our lives, because as women, especially, our families need us, our work needs us, and we're pulled. And, I don't know about you, but that's why I overate. I'd love to talk about your personal history here too, because, and then it's a good segue into that.
Like we're maybe a bit similar in that way.
I think so. Yes. I think so. A lot of work and coping with alcohol, food, and working even more and harder. So I'd love to hear your story.
I mean, I can't remember a time as a kid when I wasn't fascinated by sweet foods, refined carbohydrates. It's my earliest memory is about warm cheese, if we're allowed to talk about food. Warm cheese scones slathered in butter. I went to Sunday school. Must have only been 4 or 5, and I brought them home, and I was hysterical when I realized I couldn't eat them all myself. They had to share them with the family. I love sweets. I would always spend all my money on sweets, and I became an overweight teenager because of all that, and then started a history of dieting to try and not be overweight, but then not being able to maintain it. So then putting the weight back on and then losing the weight again. And this focus all the time around what I was eating, what I wasn't eating, what weight was I, what did my clothes fit? Did I need to buy another larger pair of trousers or whatever it was? And having all the wardrobes. I mean, I'm just a typical story, I think. I worked very hard in my career to have those achievements, and also had lovely children, so 2 stepchildren when I got together with David, and we had our own child as well, so busy at home, and I think a lot of us were brought up in that sort of post-war, work hard. There wasn't any sense of like emotional. It wasn't a thing really, looking after your own emotions.
No, it's kind of like you feeling something, go work harder, right?
Work through that. We don't want to talk about that. It's kind of sort of British post-war kind of we don't talk about emotions. That's probably why I went and trained to be a psychologist, because I kind of knew at some level that that's never going to work out. Not talking about everything. So
So
So yeah.
you're like me, you got to the point where you realize that diets, you can go on another diet if you want, but that you had a food addiction, and
Yes.
it wasn't going to be solved by the next right diet, that you had a
Correct.
brain change. And so talk about that and what you
Hmm.
realized.
Yeah, so as I say, I did this sort of low carbohydrate stuff, maybe 15 years ago. That all started, but then it soon became clear. Even though when I was kind of following that right, I did feel really well. But like any food addict, you can just mess with any food plan. So I would start making the old keto treats with sweeteners, and these like keto cakes and keto breads and I would just try and recreate all the old drug
Yeah.
foods in
Yeah.
keto form. And it was then when I was listening to Bitten Johnson that I just went, oh yeah, okay, of course, yeah. Um, so now my foundation food plan is very, very clean. No sweeteners. I actually can't deal with dairy either, or nuts, so I have to leave those to one side as well. So I personally have had to actually get really to a place of peace with my food. It's really what other people would see as very restricted, but it's
Mm.
very liberating, because then I know what I'm having. I have it. I get on with my day. I don't have to think. I don't have to make millions of decisions. I don't have cravings. I don't, it's
Hmm.
great if I'm really. And then, of course, as you said, on top of that, I had to build all the other stuff around regular exercise, a kind of a yoga practice, a kind of,
Hmm.
what else am I doing with my life? What's
You're
important
right.
beyond
Right.
beyond the work and the food,
Hmm.
particularly beyond the food. And also, I've really, really enjoyed finding this mission. I think it's great to have some kind of juicy goal, which I may not achieve before I die, but I'm working.
I'm
It
praying
keeps
for it. I'm praying. We're
it
going to
gets
get
me
there,
out
but
of bed in the
yes.
morning. I think
Yeah,
we
me
will.
too.
I think we
Yeah.
will. I think a few
Yeah.
years ago I didn't think we would, but actually I would say in the last 2 years I think
I think we will
I'm
too. Yeah.
optimistic that we'll.
And
So
we'll,
my big hairy goal is getting the condition recognised as a substance use disorder
right.
and having
I think we're,
treatment available to
hmm
people. Yeah.
yeah, I think we're going to get there. Yeah. What would you say about, well, I'd like you to talk about the withdrawal, because I heard you talk about that on a podcast, which I went through it too, where my resting heart rate was 90. Today it's like 60. My body was just throbbing with, 200 pounds
Mm.
and just,
Wow.
toxic. Um,
Yeah.
so when I started eating, food is medicine, I started eating the foods my body needed. My body
Mm-hmm.
just, but I was craving. And that's part of the
Mm.
screening of YFAS, Yale Food Addiction Scale, and Craved, that
Yes.
those addiction responses, which is one of them is withdrawal, cravings,
Mm.
and negative consequences, you still do it, kind of thing. So talk about the withdrawal and how long that lasts, and then how you feel after it's over.
Yeah. So I guess you have that sort of initial metabolic kind of switch going on and turnover, where your body's been so used to burning sugar as its main fuel, and it hasn't had that flexibility being able to kind of switch between the two, which we can now do, and which athletes and people can do. They have this sort of metabolic flexibility. So, and for me that was about 8 days. I don't know about you, but like from when I quit everything to when the lights came back on and I went, oh my god, I feel amazing. It was about 8 days. So it's, some people it's slightly less, some people can be slightly more. um i I now know that things like having some salt can be a real help. Don't
Yeah.
make that a week when you're giving a big presentation, or doing something really important. Have it as a week when you've got a bit of an easy ride going on. Don't worry about throwing yourself around the gym, that kind of thing. um Plenty of, eat. I think the other thing is, it's not a diet, is it? I think the people that we've had on the courses always want to know about the calories, and
Right.
how much should I have? And we try and say, it's at the beginning, it's not about the weight. It's about getting off the drug foods, number one, but then feeding your body all the things that it needs. So let's not restrict, because that's where the eating disorder people are right. If you restrict in terms of not enough nourishment, you're going to get this bounce back. So, and that's what we don't want. We don't want you to be hungry. You know, you may be withdrawing and your metabolism may be shifting, but we don't want you to be literally hungry for nutrition and calories. So encouraging people to eat enough protein. A lot of the women that come on the courses are absolutely amazed by what is the amount of protein that you should be eating in a day. You know, we've gone through life really not having enough protein. So get your protein in, get your fatty acids in. Have some veg if you feel like it, to, you know, bulk things out. Make it tasty. I'm a foodie. You know, I am too. Cooking. Yeah. So that's the sort of acute phase, isn't it? But, you know, there is this very long and, you know, ongoing really sort of post-acute withdrawal where you can get cravings really clang you in the head. And particularly if you're, well, we always say, don't we? Hungry, angry, lonely, tired. Halt. Those are the kind of shockers, really. And, you know, if you've had a bad night's sleep, if you've had a row with somebody, these things happen. You have a row, you know, you're not well. You kind of have a weekend where everyone else has left town and you're all on your own, and you're thinking, I'm all alone in the house. That was always a high risk situation for me, because if I was ever alone in the house, I'd be making some cake batter or some ridiculous thing.
Very similar. We could have a side conversation about this. Pizza, you know, whatever, because nobody's there, you know.
Nobody's there to see, so you kind of
see.
So hungry, angry, lonely, tired, it's always going to be a risk. So you have to be prepared, you know, mentally that you know, it isn't enough to quit the foods. You will be challenged. Your brain's going to try and force you back. The addiction wants the substance, so the addiction never go. Like you and I are still addicts. If we were to do the wrong thing, eat the wrong thing, we'd be right back in there. So, you know,
you just have to get through it, don't you think?
You have to get through.
That know that it's not going to be forever, that it's part of the process to release the toxicity and let it come out. You might have headaches, you might get tired, cravings, all of those things. All of those things happen.
Depressed, grumpy, they all happen, and they kind of come and go from time to time. It's another reason to be in a group, because you can reach out to the group and say, oh God, you know, I'm really craving this, or, you know, and they will say, don't do it.
Don't do it. You've got support here in the group. Well, as we, you know, we've got some time limit here. I'd love to, I could spend another hour or two talking to you.
Me too.
I identify with you, and I enjoyed meeting you at the conference, and loved your book and listened to your podcasts. I want to set this up for the listeners, this effort that you and Heidi Yaver have been behind. And we've talked about this before on the podcast, and mostly to people that have signed the consensus, but you are one of the ones that at the forefront with Molly and Clarissa, and especially Heidi. And so let me set this up for the listeners. A few years ago, an international group of about 40 leading clinicians and researchers reached a scientific consensus that ultra-processed food addiction meets the criteria of a substance use disorder, similar to alcohol and drugs. It is an addiction. It is a substance and an addiction, showing loss of control, withdrawal, and continued use despite harm. In other words, it demonstrates the same hallmarks we recognize in addictive substances. So you and Heidi were part of the team that led this. The consensus has fueled a global movement to have ultra-processed food addiction formally recognized in the World Health Organization's International Classification of Diseases, or ICD. ICD recognition would establish standardized diagnostic criteria, guide treatment, expand research funding, and open the door to insurance reimbursement worldwide. So I'd love to have you talk about this, as a global movement. I know there's an application in there now. There was an application before. They came back with reasons why they turned it down. You've addressed those. So talk about this effort. I'm getting goosebumps just talking about it because it's so exciting.
Yeah, and we must totally acknowledge Heidi, who tends not to do podcasts, and so she's just a workhorse in the background. So again, actually, Bitten Johnson's is part of this story because the Food Addiction Institute had always had it as one of their goals, obviously, to try and get this recognized in either the DSM or the ICD, and it's not her thing. Doing that kind of thing wasn't her thing. So when Heidi and I both trained, we both did Bitten's professional training, and Heidi said, "Oh, that's my kind of thing. I'll crack on with that." So she literally found out how it is that you apply to the WHO, how you put together an application, and what goes on. So in 2021, we pulled that together. Myself and Zippy were Livney were really part of trying to get all the academic papers in order, and submitting those. And we put in the submission, and what happens is there's a platform where people can go in and agree with it. They can make comments, they can lend their support. So lots of people did that. So that was really good. We waited, several months, and then we got this response which said, no, we're not going to recognise it because there's a lack of consensus. Number one, so obviously that was why we went off and did the consensus. Actually the symptoms are already accounted for by other categories in the ICD, by which they meant obesity and eating disorders. Well, we've already talked about
and
that.
Binge eating disorder. It's already in there kind of thing, but that's psychological, right?
They said it covered it. Yeah, so we were like, not so much.
Yep.
I'm trying to remember what the third point of rejection
there wasn't a consensus, right? You said that.
Yeah.
Binge eating.
The last one was, it would be confusing. We're like, well, that isn't really a reason. It's not a reason not to. If something's right and it exists, even if it's going to confuse people, it should be in there and it should be explained to people. Anyway, so we took all of that as a blueprint for what we needed to get on with, basically. And so, as you say, we did the consensus exercise, and there was a high degree of consensus. We got people on board like Timothy Bruton, like Kim, like David Wist, to talk about the fact that actually food addiction and eating disorders they may overlap, and people may have both, but they aren't the same. They're sort of distinct conditions. And we obviously said, well, it being confusing isn't a good reason to reject it. So the application went back in last summer, I think it was. We're still waiting to hear, but people can still go in the system.
They still can, right? And we're going to put that link in the, we'll put that link in the comments.
They can still go in and they can tick that they agree with the various things that we say, or the application overall. And they can also, there's a section where you can say, I'm a sufferer, or, I'm a clinician, or, and I support it because of this, that, and the other. And you just don't know where it is in the process or what their deliberations.
You don't know.
You don't get any feedback until you actually hear something. So we're just waiting. But at the same time, Ashley Gerhardt and colleagues have made an application to the DSM. Now, I have heard some rumours about they're overhauling the DSM enormously. So whether they're going to put a hold on new categories, I don't know where that's up to.
Right.
But it's good that we've both got them in. And I think if we got movement on either side, that would be amazing, because the other would follow, I'm sure. So if DSM agree, I'm sure ICD would follow, and vice versa.
That's what the theory is, that if one goes, the other will go. Yeah.
And also DSM have this kind of they have a kind of category which actually gambling went into before it went officially into the DSM. It went into, well, it looks like there might be something here. We're waiting for more research. But usually once things get into that category, they do end up in the DSM. So that's another thing that would be an amazing win if it gets considered by the DSM for needing more research, because then there's more funding available. And it's part of the problem at the minute is if you try and get funding for a project looking at food addiction, the funding bodies say, well, that's not a thing. It doesn't exist. So
well, it's exciting, and I think a lot will change. If it's in there, then you've got a classification. You can put food addiction in and treat it. So one thing I did want to point out is Dr. Adrian Sotomoda talked at at the conference, and he did a scientific study around binge eating disorder as compared to food addiction. And while there's a lot of overlap, there were differences. And so I believe that study went to the WHO. So it's like, it's not binge eating disorder. It's something different. So that's important to note. I guess as a closing question, I would ask you, what's next? There are people like Esther, who this is her podcast, Esther Helga, that believes strongly that abstinence is important, and then treatment for food addiction, to get the foods out and then begin to talk about past traumas, causes, and conditions. What would you say about treatment if this goes through the WHO?
Yeah, I think there would just be so much more funding for treatment studies, but the few that have been done, so ours, obviously Esther's has been published now as part of the special issue of Frontiers in Psychiatry that I co-hosted. And there's also another couple in there. So there's Susan Pierce Thompson's published data, Tro Kalajian has published data, and Ellen Bennett, who I already mentioned. So for there being no studies on food addiction anywhere in the literature, I think I'm not overclaiming to say ours was the first, but then the others that were published in the special edition after us. So there's 4 or 5 now. So that's super exciting. And they all sort of have these commonalities, which is, abstinent, because if it's an addiction, abstinence has to be the mainstay, just the same as other addictions. You're not going to get in recovery if you're not abstinent from alcohol or drugs or whatever it is. So abstinent is the base, but then all these other addiction focused psychosocial components, so dealing with trauma, if that's there, different ways of coping with emotional upset, if that's there, it really is, and getting these regular self-care habits, etc. So all of the programs have those components to some extent, and they've all been hugely effective, and our program was very effective, and people were still doing really well at 12 months. We had 62% in remission, I think, at 12 months, which is very, very good result for any
strong
program. I think the other treatments were good. So I think we've shown it can work. Obviously, you need more, and what you need really is a sort of one of these sort of proper trials where people are sort of allocated to one treatment or another, and we can kind of see what's more effective. That's all for the future.
I'm optimistic. We're making progress. We're certainly a lot farther than we were even 6 months, 2 years ago. 2
years ago.
So
it's really there's a lot going on, I think, and there's a lot more to come.
Well, good. Dr. Jen Unwin, thank you for joining me. This has been great. Just really impressed with your work, and it's been a great podcast. Esther's going to love it. And thanks for joining me today.
Thanks so much, Susan. I've really, really enjoyed talking to you.
Let me know if I can help you. The IFACC International Food Addiction Consensus Conference, is it going to be in Poland this year?
So what we're doing is we are